So welcome everybody to the AHSRI lunchtime seminar. When we moved into this building, we insisted on having theatre-style seating for 50 people. That we laid out this morning. So we're certainly making good use of this resource today, which is really good. We have quite a few visitors. I don't know whether it's the fine weather or the topic or the fact that it's our good director presenting here today, but the numbers are approximately double what they normally are. So I do apologise for the slightly cramped conditions that we have here. We normally go for an hour, and because there are so many people, I would ask that unless you have a particularly burning question, that you save it until the end of Kathy's presentation, when there will be time for some questions and some discussion. I think we have people from IRT here, we have people from Coordinaire, we have people from the LHD, we have people from People Care, we have people from an organisation that I don't know who you are, so if I've forgotten you, it's just because you're just as welcome as everybody else. If you work anywhere in the health or aged care or disability space, you would be quite familiar with the notion of consumer-directed care and its very quick emergence over the last decade or so. It's a really topical policy debate at the moment and driving lots of policy initiatives at different levels across the system. So I think we're lucky to have Kathy presenting to us on that particular subject today. I welcome everybody here, and without anything further, I'll hand over to Kathy.
Thank you. We have people in next door as well, and we also have people in Sydney. So that's a camera. Normally I would invite comments and questions as we go, but with that being the case, we've asked the other centres to turn off their mics, and we'll turn them all on at the end and open it up for questions. So I really am welcoming questions, but on this particular occasion, given the logistics of 3 different venues, I will ask you to hold off. What I'm going to do is talk to you about the concept of consumer-directed care, or CDC. And for those of you who've been in health for a long time, that means for me the Centre for Disease Control in the US. But CDC now means consumer-directed care, and I'll talk about what that means and what the ideas are that underpin it. I'm going to talk about what's happening with the National Disability Insurance Scheme and how CDC is being applied there. I'm also going to talk a little bit about aged care reforms and what's happening in CDC, and then I want to end up with some issues about what constitutes success. So that's where I'm going in this presentation. If I go to consumer-directed care, if you look in the international literature, they won't call it that. They'll call it personalisation and personal care budgets. So the consumer decides the services they want and who should provide those services. Consumer-directed, some people will talk. Most people will understand it as a voucher system. And that's the most practical way to think about it. I've assessed you. Your needs are worth 10 cents. Here's your 10 cents. Go off to the marketplace and go and buy the services you want. So you get assessed. So that's an important issue for us as health services researchers. You get allocated a budget that's for you. And usually that's in terms of an amount of money per year. And in the NDIS, the amounts of money being allocated to individuals at the moment varies from $10,000 to $250,000 a year per person. And that goes either to the consumer or their agent, and I'll talk a bit about that. And then the consumer selects and pays for the services that they want. This is a new idea to Australia. This is something from 2008 in the UK, where they have been talking about personalisation for 10 years, as has in the US, as has Canada. Social care approach, every person receives support. So the choice and control words are really important. And this slide's really important. CDC has arisen in Australia and in other countries because of a perceived failure in the way we deliver services now. That is, let's bring in the market to control failure by government and by government service providers, because services have been perceived by consumers and therefore by their advocates and therefore by governments as being organised for the convenience of providers, not the consumer, being too rigid, all the things you see here, the dead hand of bureaucracy delivering the services that people need to live independently in the community. And so that's a really important issue to come back to. There's a whole lot of problems with CDC, but the problem that they were meant to solve is we are really sick of the dead hand of bureaucracy deciding what time I'm going to get out of bed in the morning because I can't and I need someone to help me, and what time I'm going to go to bed and what I'm going to do in the middle of my day. The three benefits that are always proposed around CDC, one is different service options that actually reflect what people want rather than what governments or providers say they need. So there's a whole issue about who's in the driver's seat. The second perception is if providers have to go out there and compete in a market, that will drive improvements in quality. So that's, economics 101. And the third is people in the community genuinely want more social engagement, and they won't want to actually pay for a meal that somebody comes in and delivers via Meals on Wheels. They'll want to pay for community transport to go to the RSL club and get the $4 lunch on Fridays. And that'll be good for everybody. So that's the theory. So the assumptions underpinning these ideas, the first is really important, that needs are best met at an individual level rather than through community development type approaches. So most of the drop-in centres, the informal care systems in the country will close. The men's shed at Coniston that's had a target on the drop-in service for men, older men with mental illnesses will close because who's going to buy that in their package? You might want that occasionally. Who's going to buy those sorts of services that are around bringing together communities? The second, of course, is that the consumer can make informed choices and wants to. And if you think about the two places we've started to apply CDC, it's aged care and disability. And all the pictures are of people in wheelchairs, these wheelchairs. Actually looks like. And the third is that there actually is a marketplace. And what we know about the marketplace in healthcare is that in major metro centres there's a marketplace, and that there's a marketplace in country towns in year one, and whoever gets the contracts in year one, it's there in year two and nobody else is. So that's a really important issue, is about have we actually got a genuine market? The important issue is to understand the politics of this from a left-wing perspective, and I'm using that term broadly. This is all about consumer control, consumers in the driving seat, consumer rights, and the whole consumer advocacy movement. If you go to somewhere like Council of the Aging, this has been there, which is the key peak body for self-funded retirees and superannuants. This has been their policy for a long time. And a lot of people see that this is the beginning of an entitlement system. It's not coincidental that the NDIS is an insurance scheme, not a care scheme. Or as the NDIS likes to say, we're an insurance scheme, not a bad old welfare scheme. Of course, say this is really good. This is about more personal responsibility and about transferring financial risk from governments onto you. And we'll give you your 10 cents. And if your needs aren't met, then it's your fault because you chose the wrong things. And so it's a phenomenally good policy from a government perspective, because whether you're on the left or whether you're on the right, you inherently like this policy. And so that's a really important issue about what is it we're trying to do and how do we know that we've been successful doing it when you've got these two very divergent political perspectives. But make no doubt the major consumer groups see that this is really important because of failures in government models of care for the last 100 years. So I'll start with the NDIS. And here I am very grateful to the Disability Trust who prepared the next set of slides. Disabilities Trust, well-established organisation, this region and beyond, 40 years of experience, their perceptions of old and new, and very reflective, I think, of the broader sector. So NDIS for them is a new way of delivering support. a new approach to personalised support. You hear those words all the time, personalisation, personal budgets, that's all NDIS CDC language, and the same in aged care. Tailored to needs, an insurance approach, more stable funding, choice and control, which assumes people can make good choices, demand rather than ration, and that's part of an ecological argument that these systems should become untapped. If you need them, then you get assessed and you get your 10 cents worth and you go off and you buy whatever you like. And this is how the sector perceived the old system, and there's a whole lot of truth in it. Governments took it their money and they couldn't work out how to do with their big bit of money, so they turned it into a bunch of programs. We understand programs. And you've got 10 cents in this program, and you've got 20 cents in this program, and you've got 15 cents here, and you can't move money between programs. And programs get contracted out to providers, either government or not, and then consumers have to fit into government programs. And so they might get more of one and less of another, not because it met their need, but because that's where the money was. So the words in the sector are completely true: capped funding, limited choice, limited control. Here has been about programming and a lot of budgeting, marginal analysis, all those sorts of issues. Programs have gone under CDC. The new system, and here's the NDIS, but the same thing applies more broadly to any CDC system. The money goes to a participant. So in the NDIS language, you're not a patient or a consumer, you're a participant. And they choose the set of support services they wish to pay for with a voucher. So the language here is around individualisation, choice and control, and support, not programs. And here's a slide that I borrowed from the Department of Families and Community Services showing 100 years of disability in New South Wales, and I don't expect anybody to read it other than to say they made a point about 100 years ago we were locking people up in institutions who had aged care needs and disability needs, and then we went through various policies of discrimination and the International Year of the Disabled Person and the UN conventions on the rights of people with disabilities, ready together on the Disability Inclusion Act. And on the 1st of July next year in New South Wales, ageing disability is disappearing as the government department is being closed. The remnants of facts will remain because they are using the introduction of CDC as an opportunity to opt out of all government service delivery and transfer all of that money to the community sector and to the for-profit sector. Understand at the system level what that means. Governments have always been the providers of last resort. When all else fails, government will look after you. There is no system of last resort. Because not only do consumers have choices about the people they take, so do providers. And certainly a lot of people at the health service are very concerned that what will inevitably happen, and I think a lot of people in government are, that the providers of last resort will be the emergency departments and the prisons. So that's a really big issue for the future. So here's the NDIS in the detail. It's a national insurance scheme. That means it's an entitlement scheme. It's uncapped and not means tested. If you need something, you are entitled to it irrespective of your means, and contrast that to the aged care system and to the way we've always done things. Progressive implementation, voucher. Consumers are assessed as being eligible and then you become a participant. And the NDIS funds participants, they don't fund services. And what we've already seen in a lot of the NDIS trial sites is that a lot of the small organisations have already got out of business because they don't no longer get a block funding check to keep going. They now have to have enough money in the bank to bankroll them until somebody comes along and pays their 10 cents. And because the funding environment for the provider is now unpredictable, there's actually in many cases now emerging less choice than more, and changing the nature of providers. And I'll show you that. Bit else, eligibility, you have to be less than 65. So if you develop macular scheme and you're in it for life and you won't pay anything, and if you're 66 and you develop exactly the same condition, you'll go to the aged care sector, where you will be means tested and co-payment for exactly the same set of services, but with less choices on offer. Participants get the choice to manage how they want their plan managed. They can manage it themselves, they can have someone else manage it. So a child can have a parent manage it. There are now a whole bunch of new organisations springing up. Plan management. When I've been talking to NDIS and other providers and said, tell me about the risk management around financial and other abuse, they look at me as though I've come from another planet, because that's not part of the model. Participants get to choose their own providers, not just traditional providers, but new ones. This slide shows something from the original report done for the Productivity Commission. The NDIS was perceived to be a three-tier scheme. Tier 3, those people whose needs are lifelong and sufficient enough that they get a voucher. And in the way we're now describing. B, support for those people with disabilities, but whose needs are not lifelong and sufficient to get them into Tier 3. And Tier 1 was general community fundraising. Tier 2 has effectively disappeared. There's 200 million or 150 million or some petty amount of money for the whole country. So we now have a bimodal system. You either get in the scheme and you get a package, or you get out of the scheme and you get nothing. So the profile so far, despite the picture of the person in the wheelchair, 37% of people in the scheme, a bit over a third, are people with an intellectual disability, and another 28% of people with autism. So you'll see the whole range, but predominantly the physical disability cohort are the minority group. And one of the reasons for that is that if you have had a physical injury due to something that would be covered by a compensation claim, you're not eligible for the NDIS, and you're in the National Injury Insurance Scheme, which is a parallel scheme in New South Wales called the Lifetime Care and Support Scheme. So they're not in. This slide shows the figures as of the last quarter. 75,000 people now in the scheme, only 6% electing the full CDC option. And what's emerging already is that the wealthier, more middle class areas are opting for CDC. It's not surprising that the take-up rate is highest in the ACT. It is by far the most well-educated jurisdiction in the country, and it's not surprising that the take-up rate in the Northern Territory is so poor. We will see that CDC compared what's happening in other countries. The articulate middle class do very well under CDC because you're best able to articulate your own needs. You can manage, so the agency, that's the NDIA. 74% of people are just going for agency management alone. 6% of people are self-managing, and a cohort in the middle are going for a combination. That can be that they're managing some components of the package themselves. They may have an agent managing some components themselves. Understand though, if you manage your package and you have someone coming into your home, you become their employer. And the person becomes your employee with all of the health and safety and other insurance issues associated. And in fact, I'll cast something out a bit later that reflects on that. The second, this slide's really interesting in terms of the market of providers. If you look at the bottom section of this slide, there are 2,300 agencies in the countries that are registered for NDIS. 85% have no background in disability. And I don't know about other people. So you'll see what it looks like. And I'm not when I'm not at AHSRI, I have a number of other hats, but one of them is as a board member of the Illawarra Shoalhaven Local Health Authority. And we've been having conversations about whether the health service should become a provider. And where, as an organisation, the jury's still out on that, as it is in most other big providers around the world, around the country as well. A lot of organisations, experienced providers, are opting not to, but it's up to each organisation. And of course, you can opt in to be a provider of everything or just a niche provider. A lot of these are individual OTs, physios, etc., who can often put up their shingle, which is fine, except when you think about what most people need, which is interdisciplinary coordinated care, the idea that you go and get this from this one and this from this one takes us back almost 30 or 40 years in terms of good models of care. I do want to make a point about mental health. Mental health is really important. Mental health was meant to be included in the NDIS. Go back to the definition, you have to be under 65 and have lifelong impairment. The estimate was that 12% of those people with severe mental illness would be eligible for the scheme, but Commonwealth and states have pulled all psychiatric disability money in this country has been pulled to the NDIS. That's why places like the Men's Sheds and other things, Partners in Recovery, all those big programs that we all are familiar with, all of the money that they were being funded on has gone to the NDIS. That's because states and territories agreed to do that when they thought that the NDIS would be funding a three-tiered system. And so some of the things that they were funding in psychiatric disability were in tier 2. In fact, last night driving home, I was listening to Parliament, as you do when you're a bit of a tragic, and there was a whole question time about how can you explain the fact that one of the eligibility criteria now for Partners in Recovery is that you have to actually be approved for the NDIS first. The last point I want to make is important. Mental health has spent last 20 years encouraging a recovery ethos, and you only get into the scheme if you go, oh, that's it, I've got lifelong disabilities. Mental health in the last couple of months, some of the key advocates have actually been running a campaign quietly, and may or may peter out or it may beef up, to actually try and get mental health out of NDIS. Everybody else has been opting in. They've decided it's probably a good idea to get out because it's likely to split mental health into very tricky bits. Aged care. So that's NDIS, but I want to go back. What was the problem? It was a real problem. Parents of kids with disabilities, adults with disabilities were really unhappy about a system designed around the convenience of providers as they perceived it. Aged care. Aged care has also been reformed. The new ways you get in is through a 1-800 number or a website called My Aged Care. That really works if you think about our demographic profile. And they assess you over the phone or on the web. And if you've got low needs, you go to the RAS, the Regional Assessment Service, and we have 2 in this region, 2 RASs. And if you have higher needs, you go to ACAT, the Aged Care Assessment Team. And if you go to ACAT, you then get assessed, you might be approved for residential aged care. And the current method of funding for that is the ACFI, the Aged Care Funding Instrument. And yesterday, Minister Wyatt announced that we, AHSRI here at Wollongong, has been funded to do a major piece of work to redesign that bit of the system. The second side of that is home care packages. 4-level packages, you get approved for a package and you get a level of 1, 2, 3 or 4, and that's CDC. And used to be home and community care, which is now Commonwealth Home Support Packages, are programmed. So CDC was mandated for home care from February this year, and you can't opt out as a consumer. Have to manage a package. Advocates are pushing very hard for CDC to be also implemented in Resi and then eventually in the rest. In 2015, government announced that its intention was to amalgamate packages with the Commonwealth Home Support Program. In other words, everything would be CDC. In the May budget that just happened 2 months ago, they put that on hold until at least 2020. And I suspect that that's because there's some reconsideration going on about what does that mean. So the way it works now is that you get assessed to one of 4 packages using what's called the National Screening and Assessment Form, and some of the work that we have done here at AHSRI over the years on how to measure needs in older people has been incorporated into that form. The consumer gets assigned a package at a particular level, and they get their 10 cents. Assessment, because unlike NDIS, it's means tested, and the consumer then has 56 days, you can go for an extension, to find a provider and enter into an agreement. What we're starting to see is big changes in provider behaviour, with scouting fees and headhunting to try and sign up consumers as they walk out of the hospital door or as soon as they hang up that 1-800 number. The package includes case management, but only if you want to pay for it. And I want to again go back to who's in this cohort, what's the incidence of people who are actually able to make those sorts of choices and make sure that they don't get financially exploited and all that sort of stuff. Providers can also charge exit fees, and those exit fees can run to literally $1,000 or more if you want to move providers. Importantly, 2 things. There's no cross-subsidisation within an agency. And if I've got a package and it's $200 a week and I go to hospital and for a month I need extra services because I come out again, historically the agency could cross-subsidise. Can't do that anymore. The second is that therefore consumers are responsible for saving for a rainy day if they need to do so. If you want to have services extra when you're ready to come out of hospital, you need to have provision for that in your package. And there's a whole research question, and I went to a session recently in Perth with an organisation who were having an internal debate about the percentage of funds that consumers should save in their packages if they need it. Again, where's the overflow going to sit when that system doesn't work? Well, it's going to sit in emergency departments and in public hospitals. So this is what the rates look like now. There's 78,000 packages have been handed out so far. Don't know why we have 4 levels, we should just have 2. 71% of people are in packages of $280 a week, basically. This is the results of a small pilot that was done of CDC, and I love this. I think in terms of academics, we should be really excited about this piece of research. Key stakeholder interviews with 80 people. Found is a normally distributed curve of opinion. And the people who really like CDC are from organisations that are large, private and metro, and they're described as being adaptive. People who don't like CDC are small agencies, not-for-profit and government in rural and remote areas, and they're described as being adverse to change. And everybody else sits in between. Well, whoever would have thought it. So they're really important issues, and I really want to leave a lot of time for conversation. So I'm going to pick up this issue first. One of the things we did at AHSRI some years ago was that we developed an evaluation framework about how to evaluate these sorts of initiatives. And we made a point that you can't just use process, impact, outcome, the usual way people do evaluations, that's not enough. That we need to think about what's the impact and outcome for consumers, and that might be participants, it may be their carers, it may be communities. The second is what's the impact and outcome for providers, that may be individuals, but it may also be organisations. And the third is what's the impact and outcome for the system, structures and processes, and how we build capacity and how agile and flexible we are going forward, and our ability needs and all those sorts of things. And I think our observation from doing big evaluations over a decade is that if something only works at one level, it doesn't work. It's not sustainable. So a lot of the focus at the moment by government is, do consumers like it? But that's not really the issue, because the issue is what can we understand at all of those levels. This was in the, Peter sent me this morning, and I put it in because I thought it was so good. It's out of the UK Guardian, and I've got a copy here, pass it around, where they've had CDC for ages, and they've now granted a back pay to people who are called sleep-in care workers for people with disabilities, and about these people, consumers who are now getting back pay bills of £45,000 each, because they've been directly managing their package, but awards have kicked in and they've been underpaying people. So there's one level of happiness. But again, I don't want anyone to come out and go, gee, this is a really bad idea. Go back to the problem people were trying to solve. But there is a really big question of why would you manage your own package and take on that risk? And do you actually know that that's a risk when you take it on? Because that's really what's picking up in this. The second issue in terms of providers, and this again, Lynn sent me this morning as well. It's a busy morning this morning. The Social Policy Research Centre at the University of New South Wales, for whom we've done many, many projects over time, has published the first results from a survey of 1,500 workers working with and around the NDIS. And their perceptions of how the system's going. The first 3 dot points I've just summarised here are their perceptions of what that's like for them. 56% are saying that there's not enough time in the package to do the work that they need to do. 72% are worried about their job security. 53% disagree that the NDIS has been positive for them as workers. Their perceptions for consumers are even worse. And don't forget, provider perceptions and consumer perceptions are often very different. Most providers liked the old system. Most consumers didn't. 25% agree that the NDIS is positive, 75% don't. 15% believe that families are happy. And 16% think that the system's an improvement. The 2 emails that my colleague sent me. For us at AHSRI and for health services research more generally, there's a couple of issues. The first is this point, which is a big one for New South Wales. New South Wales government is using the NDIS and the transfer of aged care to the Commonwealth as an opportunity for government to opt out of all service delivery. There will be no programs. We have been having, and we've had a very successful partnership with the state government now for 10 years or more in terms of assessing the needs of young people with disabilities leaving school. That program itself will actually cease next year. And so there's 1,500 kids about to leave school each year in New South Wales that have had access to 25,000 kids have gone through a very successful program that's about to cease. And we're now in September, and NDIS is yet to decide what to do about it for next year. So we've got that sort of decision making, but they won't do anything about it because it'll be up to who's got something in their package. And the thing I didn't show you was that the whole economic model for the NDIS was predicated on an economic return on investment. Packages, only 8% of people in the NDIS have got employment in their package, which is actually not the system change that was anticipated and which justified this massive multi-billion dollar expansion. The second for us, I think, who work in health, both as academics and as clinicians, is what does a needs-based assessment need now in an environment we actually don't know the distinction between needs and wants? And to what degree are people buying what they want versus what they need? And to what degree are we able as clinicians to assess that? And are we able as researchers to translate the evidence in a way that allows consumers to make informed choices? Because it's all very well for us to publish our results in a nice internationally peer-reviewed journal and to get ourselves into era for university ranking. But the real issue is, if I come along as a parent how do I make an informed choice about what the right things are for my child? How do I, as a consumer, know that what I'm getting is good value for money? And a lot of the early feedback we're getting from consumers is people are charging too much for case management. It's not worth it. I'm not prepared to pay for it. I'm going to do it myself. So that's a really big issue, is assessment. And what does that mean? And particularly here where we have historically said, let's assess people's needs and let's frame the way we measure outcomes relative to those needs. And I think that starts to have big implications long term about how you measure outcomes for consumers as well, because our outcomes based on any improvement in functioning and health and independence and things we might think are important, or is the outcome now just assessed by a happiness factor of service satisfaction? And is there any distinction between consumer-reported outcome measures and consumer-reported satisfaction measures? We've always understood those to be two separate concepts. People can be very satisfied and still get a very poor outcome. Look at all the drug trials and how happy people are with placebos. But how do we actually assess value for money in a world where the concepts that we've all historically assumed as our starting points have disappeared? And also for clinicians, how do you actually know when somebody's ready to? How do you know if you work in a disability agency that you're actually delivering the care, that you're happy to go home and sleep well at night, knowing you've actually done something that's useful rather than necessarily what somebody may have wanted? So the assessment issues for me are really important because it does then flow on to bigger questions around value for money and around outcome measurement and how we link all those. And so for us here at AHSRI and for other health services researchers, they're really core research questions. But for clinicians who want to do a pretty good job every day, and for disability providers and aged care providers, they're equally important questions, but just in a different lens. And my last one is, how do you evaluate success? This is my last slide because I want to open it up for some conversation and some questions. And this is again to go back to the Centre for Health Service Development's evaluation framework. There are clearly going to be some good things and some bad things at each of those levels. And how does government evaluate success? And how do agencies evaluate success? And how do we as academics evaluate success? And how do consumers evaluate success? Given that this is a very big change away from a top-down, government-driven that knows what's good for you to a market-driven system where the market knows what's good for you and will deliver it to you. That's the end of my formal presentation. I will ask Sydney and next door to turn your microphones on so that you do get an opportunity to ask questions or comments. But I'm interested not just in asking me questions, but other comments and perceptions, because we did ask disability agencies, the health service and others to come today as well, because this is an issue I think that's very important and has the potential to become a total disaster or to have some really important success stories along the way. Comments or questions? Charles?
This seems, I'm taking a very cynical view of this. Healthcare decisions tend to be what economists call acquiescence, right?
Yep.
Typical end user, no matter how much they consider it, they're never going to know what quality is.
Yep.
And usually, they don't push decision making end user previous attributes. You push it up the channel because somebody has got the expertise to make better decisions. Does anybody really think that this idea that the end user will make decisions will create market efficiencies? Or is this just a cynical attempt to say legal costs, legal risk is too high, and push it all to the end user?
Well, I can tell you that there are people who with disabilities and people in and their carers who are absolutely clear that they are much better placed to work out what they need than a health provider. I mean, I will make a point. This is not the clinical component of the care. The NDIS does not fund the healthcare. It funds the lifelong support that goes with the healthcare. That said, there's a lot of, you know, there's big stoushes going on around where the splinting of your limb is health or disability. You know, we're back into all that sort of fight. It's not like the programs have gone away, we've just moved the boundaries. But the question you've asked is right. To what degree is information, given the level of information asymmetry, we've always understood that there is information asymmetry. I'm a really well-educated consumer. If I have to navigate one of my relatives through the aged care system or the disability system, and I reckon I know the system as well as anybody in the country, it's really bloody hard work, and I'm a really well-educated consumer. How does the average punter go? It's a really good question. I will repeat the questions as well for the Sydney Simon.
Yes, just following up on that. I mean, it is absolutely about these creating, because there's huge search costs for these. The capacity is often not there for those individuals. And more than that, if the services aren't available because we're no longer got a service care model, we've got a service model which it's going to end up as a disaster. I mean, there's no way you can avoid the conclusion that for the vast majority of people, sure, you can get people who benefit at the high end, but for the vast majority of people, it's going to end up as an absolute disaster.
Yeah, and I'll take it as a comment, and I'll just repeat it, but the comment was essentially, given that you've got a fairly vulnerable group and substantial information asymmetry and really very variable access to information to make informed choices. And then you might want to comment, we've been writing a paper together on what information is available to a consumer to make choices. These issues are really important. There will be winners. Make no doubt about it, there will be winners. And if it was somebody in my family, I'd make sure they were a winner. But I don't think these systems should be designed around people like my family. Lynn, do you want to comment?
Sure. So we've just done a review in terms of information asymmetry around what sorts of resources and supports are available to older people who are making these decisions around CBC. And basically, we found that anyone that's got low literacy, poor ability to use communication systems like phones, so anyone with how about hearing impairment, if you're an older person, speaking languages other than English, basically have very, very poor access to information. The information that's available is very general and really doesn't provide people with information that supports comparison. So if we're talking about people being able to make informed decisions, if I make this choice, this will be my outcome, as opposed to if I make another choice, this will be my outcome, it's virtually non-existent. If we're talking about people with limited capacity for decision making, so we think about the numbers that are aging with cognitive impairment in the aged care system, and this system is supposed to be for people with complex needs. In all the resources we reviewed, there was one reference to the use of a government advocacy agency to provide people with support to make these decisions, and no training for consumers to build the skills they need to be self-advocacy. So basically the system has failed. It might have provided people with choice options, but it hasn't provided equitable access to information and support for decision making.
Yeah, I think, and I'll repeat it because we've got to it off-site, that when in the research that Lynn's been leading, that I've been participating in, which is reviewing websites about what information is available, there's not enough information to make an informed choice. The other issue, of course, is if you think particularly about the aged care sector, the disability sector is a bit younger in profile, but the idea that you are expected to navigate and select via internet in a cohort, and this is not a norm, this is a skewed distribution, because one of the major reasons that you're needing home support is because you're developing cognitive impairments. And in some agencies, that's as high as 70% of people have got dementia or other cognitive limitations. So it's both whether the information's available and whether the person as the recipient is able to make good use of that information. One of the things we've certainly seen though is a lot of organisations starting to employ social marketing staff for the first time. So social marketing is making you guys might comment or hear from agencies, but social marketers have become very popular in what was previously a care system in order to get the marketing up to date, to get people to sign on. Anybody else want to?
Yeah, I work based with the kids and the parents and the families, and there was just so many different things in there. I'm going, oh, what research can I do to get this out there more too? Which I'm not research, but as you said about people going in to try and find the different needs for different. They're all on their own. They're having to go to 5, 6 different places now. They're having to do the case management. They can't do themselves, but people who are case managing are just going, oh, we'll just ring these numbers. The case managing is not being case management how I see it.
Yeah.
That to me is such a big concern, and we're right, we don't have any services. It's going to fall back on health, and we're really worried about it all.
So there's a lot of people in health who are worried, a lot of people currently working, a lot of particularly in New South Wales, where the government has been running group homes for people with disabilities since the days of deinstitutionalisation, and all those group homes are being closed and or transferred to the not-for-profit and the for-profit sector. There's a lot of concern by particularly ageing parents who've got ageing kids with disabilities about what's going. The biggest fear for an older parent who's got an adult child with disability about what happens to them, what happens to their child when they're no longer around, which is why so many parents liked institutions, because at least they felt their child was safe. The other issue I think that's an interesting one, which is the flip side, and I had a conversation through the week with someone who was telling me about a family where they had 3 children with disabilities. Each of them was individually assessed. Each child got $30,000 a year, and now they've got $90,000 because nobody family and work out what the family needs, because the unit of participation is each participant person. And that's my earlier comment, that the model assumes that the system is geared up for individual participants rather than a more collective approach that we might see through families or communities, strengthening communities.
I just wanted to talk a little bit about a piece of research that I'm writing on.
You might just tell everybody who you are. And
Okay, so I'm Shoshana Jackson. I'm here in Wollongong, Faculty of Law, Humanities and the Arts. But last year I worked for a research program at the University of New South Wales called the Intellectual Disability Behaviour Support Program. And one of the pieces of research I did with them was talking to families who have a family member with intellectual disability and challenging behaviour about their behaviour support services, because in the changeover to the NDIS, people are going to be able to purchase a product called behaviour support, and we don't have any research in Australia about behaviour support, who gets it, what works, what doesn't, how long it takes, and so on. So that was that project. But one of the interesting things about the interviews with these families around Australia was all the things families said about their lives, because as you know, when you talk to families, they often need to tell a story.
Yep.
So while you're trying to get answers to questions, tell a story. So I got this lovely data set of stories. And my background actually as a linguist, so I started to look at what families say they do, all the I statements they make. You know, I get up 6 times a night, or I rang for respite, or I didn't get whatever. And what was really interesting was what I found in that data set was not only what parents do, because we know that these families have poorer mental health outcomes and health outcomes, but what families couldn't do, didn't do, can't do, and that didn't, coupled with no. So in this CDC environment, families saying they didn't know and they don't know about certain things, and what they didn't and don't know could be categorised into 3 different areas. One was they didn't know about their person. So they would say things like, I didn't know my person was going to start banging their head against the granite bench in 6 months' time. Or I didn't know that I could have been getting respite. I didn't know you could get funding for nappies and so on. Or they didn't know things about services, both ordinary services and behaviour support services. And they also, the few families that we spoke to, didn't know things about the NDIS. So I think that sort of speaks really nicely to what you're saying around, you know, you have to have expertise, but also you have to be a particular kind of consumer And just to speak to another thing, when you Google what supports can I get under the NDIS, you get this document from the NDIS website called Reasonable and Necessary Supports. And I think that this idea of coupling reasonable and necessary with supports speaks to the clash of the original philosophy about people getting what they need with the budget bottom line, because who's going to be the arbiter who decides what's reasonable and necessary? Well, it's certainly not going to be the individual, is it?
Yeah. But, so I think I want to finish up just by making a couple of comments about what does a long-term research agenda look like for us. One is, I think there's a whole agenda around the changing nature of provision. We can anticipate that what we will see is the growth of for-profit, multi-site outlets, big companies, big chains that come in and set up 100 outlets, often big multinationals, because they've got the marketing and because they've got the sink funds to keep operating statements, etc., etc. The second, I think, is to start to really understand who are the consumers who do well and who are the consumers who don't. And an extension of that is what can be done, if anything, to improve the capacity and options for those consumers who are not doing well in this it's going to be in some places, very aggressive competitive market. And what does that mean? The third set of issues are around workforce. This whole model, and that's why we're in a business school, you know, because our issues are around social marketing, but also around industrial relations and workforce. This is really very important change in terms of increasing casualisation of the workforce, the deprofessionalisation of the workforce. Nobody is taking responsibility for workforce development or capacity building. It's now a market. So there's a big issue. Consumers do want choices, but that does assume, going back to one of my earlier slides, that there is a marketplace to choose from. And what we're seeing at the moment, I think anecdotally, is a substantial rise in casual employment for people like university students, providing personal care for people at home, which for them is great, but really raises issues around long-term capacity building. And also, given our interest and commitment here to restorative care, to reablement, to rehabilitation, how do we people with the capacity for functional improvement actually do improve in a system that's incentivised to keep you having lifelong disability in order to keep you in the scheme? So they're really important issues going forward. Can I invite our visitors who've come in, and I'm great you're here because we do have people from aged care, etc. If there was one big research question you'd like a group like ours to ask, and this is my final comment and question, what would it be? You know, you'd like go in 2 years' time, come back and tell me X.
Actually, so Josh here from my IRT group.
Yep.
I think we're actually already working on it at the moment.
Yep.
So we're curious about if the CDC environment has actually derived better outcomes for our customers.
Yep. Yep.
So, and like Lynn was just talking about, the decision-making capability of big cohorts of our customer set, but yet to be determined if they like it or not.
Yep. Other comments?
Yeah, we worked until we had a family staging.
Yep.
And we just transferred to the
So you've gone to the Benevolent Society who's got the contract to deliver services, and you're our neighbours upstairs.
We know that.
Benevolent Society has the contract to do the case management for people in the rollout of the NDIS in Wollongong.
Yeah, and that's us. I guess my concern is you mentioned safety net, that we do have people who are extremely difficult.
Yeah.
If people have a choice and choose not to bring them, okay.
Yep. Yes, the issue about what happens to where is the safety, and that is a big issue for state governments in particular, because you've got a national disability insurance scheme, and all of the safety nets are state government funded. Because at the end of the day, governments are always going to be. And so understanding who ends up in the prison cells and who ends up in the emergency departments and who can't be discharged out of hospital because no one will take them are very big issues for government going forward.
Kathy?
Yeah, the costs of health, I think, are going to be quantified.
Yep.
I think they're going to be quite real. And if there was a way of doing that, assessing what it actually costs in terms of additional length of stay, ED presentations, and service provision through health rather than through providers, I think that would be very helpful for government.
Yeah, look, it's a really good point. The whole, I mean, if you read that, it's a good read, the Productivity Commission report, where they build up an economic case for why this should happen. And that included cost savings for improved efficiencies in hospitals, improved participation in employment, improved carers would get more support and therefore they could return to the workforce. There's a whole series of issues that predicated a multi-billion-dollar investment, and there is a lot of concern. There's also, of course, NDIS in particular was never meant to replace higher education, you know, the support that we as a university give to kids with disability, or support in schools, or the healthcare, all the things that are meant to be in place. NDIS was meant to be on top, but there's a lot of argument at the margins about is splinting a health response, or is that a disability service? Is the support that a young person with disabilities needs to come to university, is that the university or the responsibility of the NDIS? Lots and lots of disputes. I don't know that we've got rid of programs. I suspect we've just moved the boundaries, and the issue at the system level is what's the overall cost and what's the overall benefits. Thank you very much.
Thank you.